So we'll go ahead and get started. So it's my pleasure to introduce our grand round speaker this afternoon. So Dr. Adriana Ioachimescu is a professor of endocrinology who's had a clinical and research focus on pituitary disorders for more than 20 years. She's heavily involved in our professional endocrine societies and journals. Currently, she serves as associate editor for Pituitary and also for Endocrine Reviews. She's also the chair for the Education Oversight Committee at ACE and is a member of the Endocrine Self-Assessment Program for the Endocrine Society. She's a well-recognized expert in her field. She has authored more than 100 peer-reviewed publications and has served on several international consensus guidelines for acromegaly, prolactinomas, and Cushing disease. So this afternoon, she'll be speaking about treatment outcomes in patients with acromegaly.
Thank you. I don't think I need so much introduction anymore. I was thinking about when I interviewed here, I talked about acromegaly, so I retrieved that presentation. I'm like, no slide should repeat itself, just make sure that this is, but yeah, we're amongst friends and colleagues here. I cannot believe it's been 3 years. It's been my pleasure and privilege to work with patients with acromegaly for so long. So I'll share with you what I know, and then we'll see whether you learn something or you find it exciting. So these are my disclosures in the past 24 months. And these are the objectives. So we're going to look into biochemical outcomes of surgery for acromegaly and how to predict remission, present efficacy and factors associated with biochemical control, because we can only control with medicine acromegaly. We cannot put it in remission as endocrinologists. We need a more definitive therapy to achieve remission. And 3, describe, and this is for both tumor targeting medication and growth hormone receptor targeting medication. So we're going to go through the whole panel of treatments available to us today. Let's start with what we have in mind when we treat a patient with acromegaly. The most important thing is that if you normalize that IGF-1, mortality is going to be the same as in general population. So we keep that in mind and we try to work with our patients to get there. But there are so many other things that we have to do for our patients. We have to control comorbidities, and diabetes is a huge one because association between diabetes and acromegaly was shown to increase mortality beyond what acromegaly would do, and I don't think that's a surprise to any of us. We want to reduce those disease manifestations. Don't forget tumor size. Let's try to control it. And in the last 5 to 10 years or so, we're able to customize to individual patients and their preferences, which I don't think it's a small thing. I hope people on Zoom are hearing me. So I'm going to start with a statement and the case. This patient asked me to present the case every time I can. Acromegaly diagnosis is still delayed in 2026. This was a lady who went on OCP for contraceptive purposes at age 17. At 27, she got married. She wanted to see if she stops the OCPs. She had oligomenorrhea and onset of acne. She saw her primary care physician, a gynecologist, and a colleague endocrinologist. They all told her, you have PCOS. You're not ready to have that baby. Why don't you go back on OCP? At 33, she was ready for that baby. The cycles never returned after stopped her OCP, and that's what reproductive endocrinology discovered. So that is one of the cases that tells you how important it is to think about acromegaly in the right scenario, not in everyone who looks like PCOS. So what this patient has is a NOSP4 invasive pituitary adenoma. So this is a coronal section patient laying down face up. So right cavernous sinus invasion with complete surrounding by the tumor of the carotid artery. In 2026, no matter how good the neurosurgeon will never be able to put this patient in remission. And you see her numbers there. You see the growth hormone? That's not a typo. 138. Okay. Years and years later, after many types of treatments, um, she never had that baby. She is on growth hormone replacement. So I keep these things very close to my heart when I think about rare diseases, because I really don't think that they're getting as much care as folks with disease that are more common. So because this happens in at least half of patients, delayed diagnosis, large invasive tumors, many patients with acromegaly require multimodality treatment. Transsphenoidal surgery by a dedicated pituitary neurosurgeon represents still primary treatment, and it achieves a rapid decrease in growth hormone levels and tumor size, and it causes biochemical remission in 32 to 85% of cases, depending on what study you look at. We define this as normal IGF-1 and a normal suppressed growth hormone after OGTT at 3 to 6 months postoperatively. Biochemical recurrence in acromegaly is rare, so it's not like Cushing. So, here's one good news. Permanent new hypopituitarism is rare with a dedicated neurosurgeon. So medical treatment will be used for persistent postoperative disease, but also for selected cases as primary therapy. For example, high surgical risk from uncontrolled heart failure, which is very rare nowadays, fortunately, from acromegaly, or uncontrolled sleep apnea, where you need to kind of work with that first before intubating the patient. Or if the adenoma is more like paracellular in location and larger and resectable, if an expert surgeon is not available, or in those situations where the patient is negotiating with you and the biochemical disease is mild and the tumor is small, and then you say, okay, let's try it. Radiation is used less frequently for those situations with persistent growth hormone excess despite surgery and meds, and also for those rare situations where tumor enlargement occurs despite surgery and meds. It's very good at achieving tumor control in more than 90% of patients. Not so good at achieving IGF-1 normalization. It's more like 50 to 70% of cases in the first 3 to 5 years. And we're talking in absence of medications for acromegaly, of course. So if 5 years went by and the remission was not achieved as a result of radiation, it's kind of unlikely that this is going to happen. And there are cases of recurrence after radiation. So if you have the privilege to following these patients for decades, you may be able to see one or two at 15, 20 years later where the disease kind of comes back. The problem with radiation, other than onset of effect, which is slow, is permanent anterior hypopituitarism in 20 to 50% of cases at the 5-year mark. You look later, there are more patients who become hypopit. And we know hypopit, even treated, no matter how good we are at it, associates increased mortality. So, if we can avoid it, that's good. What are the predictors of persistent acromegaly after surgery? Many of you know that I really like numbers, statistics, and I really like predictors. So I continue to look at it after me and my mentee from NYU, Nidhi, authored this. So before surgery, what you see in red has been shown as an independent predictor in most studies. The higher the GH level, the least likely the surgery to cure that patient, the larger the adenoma, and cavernous sinus invasion. A meta-analysis showed that 50% of patients with macroadenoma and 22% with micro will not achieve remission. So yeah, the tumor size does matter. But even more is cavernous sinus invasion, and those fellows who rotate with me, we always look at scans, and you can see that what's on the left, grade 0 through 2, are easily accessible to the neurosurgeon because they don't get too close. I mean, they do get close to the carotid artery, but they go like beyond it. Even 3A is accessible with endoscopic approach, but 3B and 4, that's a little ambitious, and there is a risk there of nicking the carotid. How about after surgery? Well, if you want a really good predictor, that's if you're sampling the growth hormone either on post-op day 1 or 2. Nowadays, patients go home on post-op day 1, but before that, there's a lot of data with post-op day 2 as well. So those are the three things that you want to keep in mind. And histology, we're not quite sure if prolactin co-secretor secretion is a bad player. I feel that Ka67 is important, but again, you have so few patients with elevated Ka67 in pituitary adenomas that when you do the statistics, unless you put a huge number of patients together, they're not going to show up independent. So it does younger patients, yes. I mean, younger patients tend to have some genetic syndromes or familiar adenoma associations, so they may not do so well as well. They may have more aggressive tumors, but there are not so many, fortunately. So, and that's why it's not in red. How about female gender? So this comes from a very large study. If you look at the numbers up top from South Korea, and women who are premenopausal, what you see there, that they have lower preoperative IGF-1 level, and that's because of their estrogen and because you produce less, because of the effect of the growth hormone receptor. They are premenopausal, which kind of plays against them because the disease is not as physically apparent as it is in males. So they had, in this particular study, more macroadenomas than males in the same age group, and a higher number of invasive tumors if you look at the KNOS grades. So you see there the P is significant. And then the same females, premenopausals, had the lowest postoperative remission rates compared to males or postmenopausal females. So it's something to keep in mind, but it's just this one study, even though it was huge. I think it had more than 400 patients in it. This is our work from Emory. Dr. Anthony was my fellow at that time. So what we did, we put on this ROC to the left. You see preoperative growth hormone levels, just like random, not post-OGTT. And what you see on the right is you see the IGF-1 predictive value. And you don't need numbers. You just look at it. And it's like, yeah, none of them are great, but the better one is the growth hormone level. And what we keep teaching students about acromegaly is like, look at the IGF-1 is the average growth hormone over the past status over the past 3 months. So why is that? Well, actually, Dr. Barkan showed this in 1988 when he was sampling the growth hormone levels every 2 hours in his research unit. There is only and if you inject the growth hormone, right? So there's only so much that IGF-1 production by the liver can go up by. So at some point it reaches a plateau. So that's why the pre-op GH levels are more correlated with the outcomes, because no matter how bad the acromegaly is, I don't think you've ever seen an IGF-1 level greater than 1700. That was my greatest one that I was able to see. So if you try what you've seen is like several things are important, and the statistical significance or independence comes from tumor size, growth hormone levels, and cavernous sinus invasion. But really, we are in the AI era, right? So we have to play with this. We have to do modeling. So we only had 79 patients in Atlanta, but that was enough to show that if you look at GH levels, again, random, tumor diameter, and cavernous sinus invasion, you get to a very good prediction of 0.933. While if you just look at the radiological parameters, the way the neurosurgeons are typically, they are only at 0.8. So, we learn from each other and we help each other. But then obviously a study came from China where they actually it's been almost 700 patients, 6 machine learning algorithms, and they looked at univariate predictors, and then they they figured out the model. Guess what? Preoperative GH level and cavernous sinus invasion grades remain the top of the predictive. So when you see a patient with acromegaly, yes, tumor size does matter, but how much it goes to the cavernous sinus matters a little more, and then the pre-op GH level. Now, if you want one single predictor that's really good, that's immediate post-op GH level, similar to what you see with the cortisol level in Cushing disease, right? I mean, look at the area under the curve, 0.9, right? And this was our data, but if you look at the literature, everybody who looked at it said, yeah, this is really good. So I don't quite know which number to pick because growth hormone assays change over time, but I would say less than 2 nanogram per milliliter on post one. It's a pretty good thing, and we're getting it. So for fellows, when you see a patient and so on, just look at that, look back, see when were they operated, what was the GH level next day. Okay. So moving on to medical treatment of acromegaly, right? So we have tumor targeting meds and we have growth hormone receptor antagonist. Among the tumor targeting meds, we have SRL, somatostatin receptor ligand, and we also now have an agonist available. I mean, there is a difference, right? You can make the receptor do what you want it to do, or you can bind directly to the receptor, right? So there is a difference. And we have dopamine agonists, which are approved for prolactinoma, but not for acromegaly frequently. So what do we expect from this category of medicines? A decrease in both GH and IGF-1 levels and tumor shrinkage or control. Like we take control many times, even if it doesn't shrink, as good news. What do we expect from the growth hormone receptor antagonist? Because it decreases the IGF-1 production, which is mostly by the liver, we expect IGF-1 level to go down. Growth hormone levels, we don't even check. If we check, they're going to go up a little. Not necessarily because of a rebound secretion, but because pegvisomant interact with the assay. So it's like, don't get it because the patients will get concerned and there is no need to get concerned. This is our latest consensus guidelines with all these different branches and so on. And I do realize that it's no matter how big I try to make it, it's still small. But surgery is recommended as primary therapy. And then in the middle, we have the injectable SRL that have been the mainstay of therapy. There are some situations where IGF-1 levels are minimally elevated, and then you can use cabergoline off-label. And then there are some situations where the tumor residual is very small or invisible, and the patient is, and in that case, you can start with growth hormone receptor antagonist. Pegvisomant is the only one we have. And then many patients are not in control with monotherapy, and then we have all sorts of switching, swapping, or combination therapy. And radiation you see somewhere down there as a third line. This is the timeline on FDA-approved medications for acromegaly. We've gone quite far from 1988 when subcutaneous octreotide came around, and then soon thereafter octreotide LAR. So throughout this presentation, ISRL mean injectable somatostatin receptor ligands. After octreotide, there was pegvisomant, which is a growth hormone receptor blocker, which is competitive. So you don't get to the deficiency from it. Then we had a very similar drug with octreotide called lanreotide, which also targets somatostatin receptor type 2. That's called lanreotide. And then in 2014, we had a multi-ligand. So it's still injectable, but it's multi-ligand, and I'll explain why it's different. 2020, oral octreotide. Octreotide is a peptide. So the mechanism, the advances in medicine to be able to give a peptide by mouth. I mean, I think these are incredible times we live and are able to help our patients. And it's octreotide, so it's still SSR2. And then last year, paltusotine, and that's the one that I was telling you about, that is an agonist, is not a ligand. but it still acts on somatostatin receptor type 2, and it's still, it's another oral medication. So let's go through them. This is the, what you see here first is, is the group of medications that act on SSR2. So I told you before, octreotide and lanreotide are the same. There is only one difference, and that is in duration of action. And in administration, of course, it's deep sub-Q, while octreotide LAR is intramuscular injection. Biochemical control, 30 to 60%. Now, this is control. It's not like my IGF-1 is getting better, it's getting normal. Adenoma shrinkage effect, yes, shown by studies in both of them. Main side effects, nausea, abdominal cramps, cholelithiasis or sludge in many, and of course injection in related pain and nodules and so on. We then have octreotide that is oral, which the name, you see the brand name in parentheses, which is an oral medication administered twice a day on an empty stomach. And you see there the biochemical control from clinical studies. And we don't have enough information about shrinkage yet, and the side effects are the same, minus injection related. And the new kid on the block, paltusotine, which is the agonist for SSR2. And you see there the efficacy compared to patients who are previously in control with the injection of octreotide or lanreotide. Same type of side effects, and it's once daily fasting administration. The multi-ligand pasireotide, the difference is it binds with high affinity on SSR5. So another subtype of receptor, which is also involved in control in acromegaly. So it's expressed by the tumor cells. Similar to octreotide is IM injection every 4 weeks, biochemical control in about 50% of patients, but data is more nuanced here. I'll show it to you in a minute. Very good adenoma shrinkage effect, and the side effects are a little bit more numerous. You do have to get a pre-op EKG just to see where the QT is when you start, and then you have to get it again just to make sure it didn't get longer. And finally, growth hormone receptor antagonist, pegvisomant, subcutaneous injection daily, even though many patients are able to take 3 to 4 injections per week if you kind of do the math. Biochemical control in real life studies about 70%. There is no adenoma shrinkage effect, so you have to be careful here. Main side effects are very rare, increased transaminases and lipodystrophy at the administration site. So our mainstay still is ISRL, in particular octreotide and lanreotide, and these are long-acting medications. They bind with high affinity to somatostatin receptor type 2, and they have efficacy. It's like flipping a coin, really. And if you look at both growth hormone, like growth hormone should go below 1 nanogram per milliliter, and IGF-1, it's even less than half of patients who achieve full control if you're really ambitious to get the growth hormone low as well. They do achieve tumor reduction by more than 20% of maximal diameter in more than 60% of patients. And this can happen even if IGF-1 was just improved and not controlled. And the primary SRL treatment, so before surgery, obviously those studies showed more tumor shrinkage than those postoperative studies, because postoperatively you may just have a small residual and it's harder to measure. Extended interval is only approved for lanreotide. I saw this week a patient who is trying to balance the side effects that she feels come with octreotide LAR with less frequent dosing, and the numbers are not in control, right? Octreotide LAR does not do this. It's really the formulation of lanreotide that allows it for extended interval. The studies clearly show it. You can see there some patients need it every 5 to 6 weeks, some patients every 7 to 8 weeks. If you go beyond 8 weeks, no, that's not going to last. And FDA approved it for an extended interval. So because we had access to these medications for so many years, we have a lot of predictors of success. Younger patients, less response. Women respond better than men, presumably because of SSR2 upregulation by estrogen. There are some anthropometric predictors. Those who have higher BMI respond less well. Diabetes also associated with less response. The higher the IGF-1, your starting point, the lower likelihood of complete response. And then there are some imaging characteristics. How big is your battle, so to say, right? Larger size, extracellular extension. And in Europe, they also report the T2 hyperintensity. This is not reported in the US, and we're not using it much, but it's becoming more and more used in clinical studies. Tumor histopathology, densely granular, good thing. When you see that in histopath response, that patient most likely is going to respond to octreotide or lanreotide. Sparsely granular, less response. The best predictor is somatostatin receptor expression, and we can have immunohistochemistry for this as well. So you can look at how many cells express it and what's the intensity and calculate a score. You won't find those scores unless it's a research project, but you will find in our reports the fact that the tumor does or does not express somatostatin receptor type 2. And then Ki67, at pituitary adenoma you should not see mitosis. You should not see Ki67 greater than 3%. It's not specific to pituitary, but it's not good news, in particular if it goes close to 10 or above. So this is one study showing how older age and female sex predicted biochemical response to primary lanreotide therapy. Also, if at week 12 you saw a significant drop in GH, IGF-1, and some tumor shrinkage, that's going to be reassuring that this effect is going to be carried over in the long run. This is work we did at Emory, but we didn't publish because there weren't too many cases, but I still feel that it's very interesting. Maybe I'll get this data in one paper somehow. So we looked at distribution of somatostatin receptor 2 and 5 in 76 growth hormone adenomas. So what you see there, so 2 is blue, 5 is gray, and most tumors express something, less than 10%. So what's the percentage? Percent of cells that express it, okay? So very few tumors don't express this, but if you look at 80 to 100% expressing these, well, that's around 60% of the tumors tested. So then, in only 23 patients, we had information with normalization of IGF-1 on octreotide or lanreotide. Now, this is pretty neat. Nobody who has SSTR2 receptors in less than 80% of cells achieve normal IGF-1. So yeah, it's nice that the pathologist is telling me that the receptors are done, but it would be much nicer if they told me how many cells have that, or if they calculated the scores. There are some, around that time when we did that, the scores came around. So scores is really multiplying the percent of cells positive with the intensity. And then we looked at the other predictor, which is the densely granular pattern. And if you combine SSR2 with the densely granular pattern, then you get to an area under the curve of 0.96. So they're not completely overlapping. They don't mean the same thing. So now when you have patients with acromegaly, look at that. Is it densely granular, sparsely granular? Do they have receptors? And I think, by having these conferences where the neuropathologists join us, it's kind of nice because we get to bring those cases up to them and say, okay, show us the images. Where's most cells that express SSR2 or just some? So there's a lot of nuance here. And this is also a lesson for the fellows. If you have interesting data, publish it before someone else comes in with something cooler and much more cases, if you can. So why oral medications for acromegaly? Well, this comes from patients. In the last 20 years or so, we had in all fields of medicine, patient-reported outcomes became important. And our clinical research now has to have some aspect of patient-reported outcome incorporated in it. So some patients are telling us, well, I don't feel as good right before my injection. And we're like, your IGF-1 is fine. Why don't you see whether something else is going on? But look at the study and how it shows that it's not a flat line. You get the best IGF-1 control somewhere between day 7 and 14 after getting the injection. So that's one issue. And then another issue, and I heard this over and over again, in particular from those patients who volunteered for the oral octreotide studies that I led at Emory. They did not like the fact that they felt sick every month when they were coming to either the medical institution to have that injection. Even like back in the days, some insurance companies would pay for the nurse to travel to patient's home. And you could figure out, okay, on Friday, but that's like time lost from work. I don't think the nurse would come on Saturday. And again, you're kind of, that day is my day of getting this treatment. It's almost like I have a cancer, right? That's how they look at it. And when they get the infusion, they get it at a cancer center. That's the first thing they see every month when they walk in there. So there was a push, from the patients to kind of do away with the side effects from the injections and to try to be more independent and not be reminded of their treatment every month through an infusion center visit, right? So oral octreotide. The wonderful thing is that I think the discovery of this transient permeability enhancer is going to allow for a lot of other medications to be delivered orally. So they transiently open, just for a short period of time, these small tight junctions, not enough to cause a problem with infection or anything like that. So 2 phase 3 clinical trials showed non-inferiority from the injectable SRL octreotide and lanreotide. And one of them was called Optimal, which was placebo-controlled, and the other one was called Empowered, which was open label. And I think the problem with both of these is that they picked patients who are previously controlled. Like they thought we're treating with the octreotide, which is already approved. So they chose their study participants from people who are already controlled with this. So that's what FDA put in their approval. This is approved for patients who demonstrated a complete or partial response to injectable SRL. That's what the study did and showed, and that's what's approved for. It's initiated at 20 milligram BID. So, the first pill, you take it with your levothyroxine. Okay, the second, figure out either in between meals or at bedtime. Dose adjustment every 2 weeks. Faster, right? With the injectable octreotide, lanreotide, pasireotide, you have to give 3 injections, then get a level before the 4th, and then you can up the dose. With this is much quicker. Similar adverse event profile with the injectables, except, of course, no injection site reactions. So this was the study that was placebo control, and they started out in control with injections, and you can see here in black the oral octreotide patients, and you can see in gray the placebo patients. And yes, you can ask me about this, and yes, I can explain about this. Not everybody who is getting injectable SRLs actually need them. So that's why you see the placebo maintaining normal IGF-1, right? So sometimes you have to revisit this. Sometimes patients stay on octreotide or lanreotide based on whatever small elevation of IGF-1 level at 3 months post-op, but maybe had they waited 3 more months or taken a break once in a while. I mean, I had this surprise in my practice when someone lost insurance and they came back after a year and their number was still normal. So I think that's how you explain the placebo maintaining effect as well. So how about paltusotine? So that is the oral non-peptide selective, highly potent SSR2 agonist approved last year based on 2 phase 3 clinical trials, Pathfinder 1 and 2, one open label, one placebo controlled. They did have patients who not everybody was previously controlled, so the approval was similar to octreotide and lanreotide injection for patients who have an inadequate response to surgery or are not eligible for surgery. So it's not just for those who were previously controlled. It's initiated 40 milligrams daily on an empty stomach, and dose adjustment is made after 2 to 4 weeks based on symptoms and IGF-1 level. Similar adverse event profile with the injectable octreotide, except injection site reactions. And that's Pathfinder 1 results, where you see in blue the medication that was tested, paltusotine, with 83.3% controlled acromegaly, and only one patient, 3.6% with placebo. So in a nutshell, switching to oral somatostatin receptor ligand or agonist has some benefits to avoid pain and nodules at the injection site for those patients who encounter this problem, to avoid the burden of monthly injection by a nurse, faster IGF-1 faster IGF-1 based titration. You don't have to wait 4 months with uncontrolled acromegaly to increase the dose. And there is a potential in decreased IGF-1 variability and symptoms because it's something you take every day. But that's the main caveat as well. You have to remember to take it every day. And for the medicine that's given twice a day, I mean, there's so many studies in general medicine, hypertension treatment, and so on. The second pill you can forget, right? So that's the main caveat. Are you going to be able to take it every day? Now you go, you look, infusion center note, you can tell exactly when your patients got the treatment. It's in, right? With oral medication, it's you have to have a system. GA factors may alter absorption, drug interaction may decrease availability. PPIs are a big one. Long-term tumor control data still requires some information, and combination therapy data we don't have. But overall, I think it's a wonderful option for those patients who are either not tolerating or not liking the fact that they have to get an injection for their tumor every month. And I can tell you that those patients who switch are very motivated, and they want to be in control, and they are motivated to try without the injection for a very good reason. Back in the days when lanreotide was approved for self-injection, this changed after the FDA approved it for neuroendocrine tumors, because once the cancer center started to give it in their infusion centers, then the FDA changed the level, so our patients could no longer inject their lanreotide by themselves, which they were able to do it because it was deep sub-Q, right? But obviously not everybody can necessarily administer even a deep sub-Q injection. So I remember some patients of mine who were interested in the oral medication and qualified for the trial. I mean, they were like, I have to go back and see my parents every month because my dad can inject it. I don't necessarily want to see him every month. This is an imposition on me that I have, so there are so many reasons that people consider, like taking control of their own health and switching. But not everybody wants to switch. So how about pasireotide? So this was approved, again, is approved in everybody with acromegaly who's either medically, who either does not qualify for surgery or did not achieve remission. So it's not all, it's a different type of ligand because the affinity for subtype 5 somatostatin receptor is much greater than anything else that I talked to you about until now. So the biochemical efficacy was proven in a phase 3 head-to-head study where octreotide LAR performed so badly, only 20% of patients remission, and pasireotide had 31%. And then it was another phase study. So as you can see, like for all these rare diseases, you need 2 controlled studies for FDA to approve it nowadays. And one of them nowadays has to be placebo-controlled. And then when they did it, so the PAOLA study was in patients who were previously uncontrolled on octreotide and lanreotide, and 20% of them achieved controlled pasireotide, and then they maintained, or even their number of responders increased over time. It does have a pretty good effect on in most patients in terms of adenoma size reduction. In head-to-head study, there were no differences, but then the literature is abundant on cases where tumors that were stubborn are finally decreasing in size. And this is the one of the studies that brought the FDA approval, and you can see there overall patients. Just look at the first group of data. In black, the new kid on the block, pasireotide LAR, and in gray, the octreotide LAR. Very clear difference in terms of a combination of normal IGF-1 and low. And this is the PAOLA. So what you see here in study, what you see in green, is patients who remained on their pre-study medication. And then if they went on pasireotide, they tested 2 doses there. Their IGF-1 and growth hormone levels improved. That's blue and red. Nothing is perfect in life or in medicine, right? Pasireotide comes with a hyperglycemic effect, and pasireotide is approved for both acromegaly and Cushing. And the effect in Cushing disease is much more pronounced than in acromegaly, but this was then demonstrated to be related to decreased insulin and incretin secretion. So the same subtype 5 that gives you the advantage in terms of tumor effect, it gives you a disadvantage when we're talking about pancreas. So the good thing is we can predict, right? That's my talk about prediction, who will have pasireotide-associated hyperglycemia. It's pretty much everyone who has metabolic syndrome. If you have metabolic syndrome, which about 30% of patients with acromegaly do, it doesn't have to be type 2 diabetes, then you're at higher risk for pasireotide-induced hyperglycemia. And that, so far, in my experience with a relatively small number of patients, because we keep this medicine, as in our back of our mind, if they don't respond to the other medicines that don't cause diabetes, right? So far, this works. I mean, you don't have to look at metabolic syndrome. How about cabergoline? Actually, it's not approved for acromegaly, but has been extensively used. It works because any pituitary adenoma can express dopamine 2 receptor. Now, we don't test for this by immunohistochemistry or with imaging, so it's more like a guessing game. The more receptors you have, the more likely you're going to respond. The effect is modest, and we don't have enough information in terms of tumor shrinkage. You all know the side effects from dopamine agonists from your prolactinoma patients. The GI side effects typically improve over time, lightheadedness as well. And there are some things, valvulopathy, psychological changes, which are, big nowadays because we didn't know about them until recently, and we don't have data on acromegaly. And we should have data because the dose required to control acromegaly with cabergoline is larger than the dose we need for prolactinoma. So that's a meta-analysis. Each patient is represented here, and you can see IGF-1 levels improve, but not too many get to the dotted line. Predictors of response, lower IGF-1. So if you want to try it and your IGF-1 is only 50% above upper normal limit, why not? The next thing is, so those are studies that were published after the meta-analysis. There is only one prospective, but it had 24 patients and only went on for 18 weeks. That was the worst in terms of the outcome. Only 11% of patients responded. In general, is about a third of patients normalized their IGF-1. If you combine it with octreotide or lanreotide, about 50% get to the dotted line. Predictor of response, again, the lower baseline IGF-1. If you have a big problem, don't try cabergoline. It's not going to do enough. Now, this guy is going to do a lot. Pegvisomant is our big gun because it blocks in a competitive fashion the growth hormone receptor. So I told you already, we just look at IGF-1, not at growth hormone levels. And the pivotal trials in the 80s showed an efficacy of 95%. Too good to be true, right? So then ACRO study is, we all put our data, we all put our patients medicine all over the world. And guess what? Only 50% were in control at 1 year, 75% at 10 years. But most patients received doses less than 15 milligram per day. The maximal approved day is 30, but we can give 40, and we know the higher the dose works. So 40 sometimes is needed. So what we thought here is that in real life, folks are not very, clinicians are not very eager to increase the dose. They get pituitary tumor enlargement, about 7%. Again, we're not doing anything to the tumor. So if that's your only medication and that tumor is bound to grow, it's going to grow. It's going to do its number. Very small percent of transaminitis and very small percent of injection site AIDS. But those are very unpleasant when the lipodystrophy occurs, and it's just very, people don't stay on it if they develop it. So that's one of the landmark initial studies. Each patient, other than one, reached their IGF-1 goal. And this is the ACRO study. And what we see here is the proportion achieving control in green, getting higher and higher over time, but really not to the 90% mark. And when we look at the doses in the lower part, in the lower graph, you see there that most patients received doses in between 10 and 15. And very few were up titrated to 30. So do we have predictors for pegvisomant response? If you want a quick answer based on multivariable analysis and independent predictors, that's in red, high IGF-1. The higher the number you start from, the lower the likelihood of response. But there are so many other things going on in that graph. And what I've learned in my clinical practice, and I don't know if Lisa Marcel is on as well, because we were sharing one of these patients, uncontrolled diabetes and obesity, it's very hard to get acromegaly patients in control. So we are now at a place where the GLP-1 agonist addition to this patient population actually might be favorable from acromegaly control as well, because you get to your response from pegvisomant easier. But we don't have that data, but it's definitely important. So this is one of the old studies showing that women need higher doses per body weight of pegvisomant for control than men do. And this is the very important difference between pegvisomant and the other medications that I've talked about. It improves glucose metabolism. And in this particular meta-analysis, the effect on glucose A1C was independent on IGF-1 lowering. So it's good for patients with uncontrolled diabetes. Octreotide and lanreotide are kind of glucose neutral. So you add the pegvisomant, you improve diabetes. Now that brings me to the combination therapy. The classic approach is to achieve maximal dose of octreotide or lanreotide. You up titrate, you're 6 to 9 months later, and then you add pegvisomant or cabergoline depending on how high is your IGF-1 from upper normal limit. The alternative approach, of course, insurance permitted, is to use lower doses of two medications. They are synergistic, and it's been demonstrated that have lower cost by a Cedars-Sinai study. And also the potential for side effect with using smaller doses might be less. You monitor LFTs if you do combination, and we need larger studies. But going back to the diabetes, so remember how pasireotide was good in terms of tumor shrinkage and IGF-1 control, better than octreotide, but was causing diabetes. You add pegvisomant to this, nothing happens. You cannot beat that. The pasireotide effect on incretin and insulin, you cannot beat with added pegvisomant. You have to treat the diabetes independently and very aggressively if you need that medication. So if you see here, these people were on two medicines, pegvisomant and octreotide. They replaced with pasireotide to see if they can only use one medication. And that led to an increase in diabetes prevalence from 33 to 69%. So pegvisomant and pasireotide is not the solution to diabetes. This is one of the patients we treat here, and she gave us permission to present her case and so on, just to kind of get a flavor for what happens in the practice of folks who treat acromegaly. So Diana started treating her, and they were after surgery, she was able to get pregnant, and then she wasn't treated during pregnancy and lactation. And then octreotide did something, but didn't do enough. You see the green line, upper normal limit. So then we increased the dose, we gave her pasireotide. She didn't really have patience for A1C elevation. She didn't like to see that. Patients don't like to see a new endocrine disease coming around. So she's like, I'm not staying on this. So I'm like, okay, well, let's switch from octreotide to lanreotide. Let's add pegvisomant. Let's increase the dose. Finally, we got where we wanted to be. And now she's like, well, can I talk to you about my nodules and my pain? Can you switch me on something else? So that's where we are now, right? Because up until now, of course, we were all focused on normalizing her IGF-1 level, but now she's interested in oral medication combined with pegvisomant, which doesn't have a lot of data, but it makes all the sense to try to cater to her needs, because she's been through a lot and she's young. She's only 55, so she's going to be at it for a while. Her tumor has invasion in both cavernous sinuses. She went to Stanford, after coming here. She sought second opinion. There's no way this is going away. So this is Nate's experience. So Dr. Zwagerman, we looked at his acromegaly experience in how many patients were here? I think 50 patients were operated since he came, and followed on for a median of 31.7 months. His practice is very different, or initially was very different than other neurosurgeons' practice, because a lot of patients who were previously operated elsewhere came to him. So 11 out of 50 were reoperated. When you reoperate, your chance for removing old tumor without a lot of damage are less, because there's scar tissue that you're fighting against. So it's a very different type of, this is changing obviously now, but it's about 50% remission as a result of surgery at the at last follow-up, and the others, in 24.5% of the others, achieved control with medical treatment or reoperation or radiation. And this study is a student project. Maggie Allen is doing a great job on it, and we're almost ready to submit this for publication. And Caitlin, I mean, a lot of people have helped, but Caitlin Madden, our research coordinator, I don't without her. So we're doing a lot of work here to try to figure out where we are, even with rare diseases, and at MCW and Freighter, and we're getting really nice results for now that the REDCap database is all prospectively collected, and we got to today. So in a nutshell, growth hormone secreting tumors, primary treatment remains surgery at centers where neurosurgical expertise and multidisciplinary tertiary care are available. Medical treatment is needed in about 50% of patients postoperatively. They can be identified by us based on preoperative radiological and hormonal characteristics, as well as early post-op GH levels. Personalized treatment is possible. Nowadays, we can consider comorbidities, diabetes as in the front of our attention, patient preference, now oral versus injection, of course, insurance coverage and cost. And I want to finish with this Osler quote because that's the reason why I went into medicine. What it just says there, to practice with my head and with my heart, and I'm grateful, for everything and for being able to help patients with acromegaly. Thank you. Any questions?
The lady first.
Oh, no, I didn't.
It's going to be very fundamental, basic questions that I always wanted to ask, but didn't have opportunities. I don't have much time left, so I'd like to ask. The first question is, you know that the diabetes all effect of the somatostatin, you think? Or something else? In other words, ACTH secretion. What about ACTH secretion at acromegaly? I mean the pituitary adenoma.
So I think specifically to acromegaly, hyperglycemia occurs in context of insulin resistance.
Because of insulin resistance?
Yes, so the
word corticoid secretion?
No.
Nothing to do with it.
Not in acromegaly. The growth hormone and ACTH cells come from two very different lineages.
Mm-hmm.
Plurihormonal adenomas that express these transcription factors that lead us either on corticotroph or somatotroph lines are extraordinarily rare, less than 2% of adenomas. So we almost never see a patient that has both ACTH excess and growth hormone excess. But it is very different in Cushing disease, right? Did that answer your question?
Yeah, so Cushing's disease is somatic cells other than alpha cell. I understand alpha cell is causing the acromegaly, right? Alpha cell in anterior lobe of the pituitary gland.
So it's all of them are in the anterior lobe, but it's like somatotroph, lactotroph, corticotroph, yeah. Yeah, and corticotroph is a different lineage.
Okay. I solved one problem that I had when I was...
Yeah.
Which cells secretes HTH? Do you know? Or different cell?
Corticotroph cells, yeah.
It's a different cell.
It's a different cell than somatotroph.
So Cushing's has a different type of cell.
Yeah.
All right.
But I think what you may be thinking of is those really old times when cutting the stalk, the infundibulum, may improve diabetes retinopathy, right? Because of the no more hypothalamic stimulation to the pituitary, right?
Yes.
But that was a very different time, and we no longer need to do that, right? So.
Well,
Yeah.
I asked the question.
Yes, absolutely.
Thank you.
And I'll just, oh, you want to go ahead, Jenna?
Oh, whatever. Doesn't cabergoline also increase IGF-1?
So in patients with prolactinoma, if they had low or low normal IGF-1 and that was a big tumor, IGF-1 is going to go up a little. There are some situations where IGF-1 is normal, prolactin is elevated. You treat as if that patient is a prolactinoma because prolactinoma is treated with dopamine agonist as primary therapy. And then a year or two later, they change the doctor, someone gets another panel and their IGF-1 is elevated. So those cases are rare and we don't quite understand them, but there is some plasticity of the pituitary cells. And so sometimes it's transdifferentiation. Other times is like you can favor one population of cells versus other, right? Mm-hmm. So prolactin and growth hormone, they come from PIT1 lineage, right? So you may have a population of cells that is kind of asleep, and then you treat with cabergoline the prolactin secretion and the lactotroph cells, and then the somatotroph kind of become active. But then there are other tumors that are mammosomatotrophes, and then there are other tumors that may originate from like an earlier, like a grandma of the somatotroph, and those are not necessarily good news when they're, yeah. So those cases do happen. I had one. I didn't report it, and now that I'm trying to write about it, I'm looking at the literature and. Yeah, it's very interesting. Sometimes this happens. In fact, in our guidelines for prolactinoma, we said, please recheck IGF-1 level periodically. We don't say when, but during therapy, you check it at baseline, but check it later. And if it's gone up and you did the OGTT and it's positive, then the patient needs to go to surgery if there is a big tumor still there. You're right. Yeah.
I also have one more question. So on the pathology reports, as you mentioned, sometimes they'll comment about SSR2 staining. They don't give the percent, but if it's poorly staining, does that change your approach in terms of what medications you start off with? Are you more likely to start with pasireotide or not?
No, I never start with pasireotide because none of this data is 100%. It's statistical data. If I have a choice of controlling this tumor, even though it's low likelihood, and I can use an SSR2 agonist without causing diabetes, I prefer to use the pasireotide later if needed. But I may choose pegvisomant if there is not a big residual, right? But I have to watch the tumor. But so far, I have not started with pasireotide, and most of the community of experts, they don't do it. I mean, we're all endocrinologists, so we don't really like to cause hyperglycemia. But there are, and also if it's an aggressive tumor, you may not necessarily know right away, right? In that case where the Ka67 is 10, let's just give an example. I think you need to give radiation. When you need to shrink the tumor, you need to remove most of the tumor with surgery. If you can shrink it some more with medication for a few months, but then give radiation because that thing is going to go out there and you're going to need temozolomide, and it's just going to be a little harder. So I still don't try pasireotide as the first line medical treatment based on all the data that happened. But during the course of the disease, yes, we may. Anything online?
No, nothing online.
Thank you.